In this video, we will discuss study design in physical activity epidemiologic research. The goal of a good study design is to ensure that comparisons between groups, based on differences in physical activity or fitness, are not biased by other factors. In other words, the design determines whether we can reasonably conclude that physical inactivity is a direct cause or a key explanation for outcomes such as injury, disease, or death. Here is an overview of the main types of study designs. There are two broad categories: observational studies and experimental studies. Now let's compare observational and experimental studies. The key difference is whether there is an intervention. In observational studies, researchers do not intervene. They passively observe participants and collect data as it naturally occurs. The main types include cross-sectional, case control, and cohort studies. In contrast, experimental studies involve active intervention. Researchers manipulate one or more independent variables to examine their effect on outcomes. In this course, we focus on randomized controlled trials. Randomized means participants are randomly assigned to different groups, which helps reduce bias and strengthen causal inference. Now we will take a closer look at the different types of observational studies. We will focus on the main designs: cross-sectional, case control, and cohort studies, and examine how each is used to study relationships between exposures and health outcomes. A cross-sectional study is the simplest type of observational study. It involves one-time data collection, where both exposure and disease status are measured at the same time. This provides a snapshot of the population at a single point in time. There is no follow-up. Participants are assessed only once. Researchers then compare the occurrence of disease between groups based on exposure status. Because cross-sectional studies collect data at only one time point, they are relatively easy to conduct and cost-effective. They are especially useful for estimating prevalence, such as the proportion of a population with certain diseases or risk factors. Large public health surveillance systems like National Health and Nutrition Examination Survey and Behavioral Risk Factor Surveillance System, conducted by the Centers for Disease Control and Prevention, use cross-sectional designs to monitor conditions like obesity, diabetes, and behaviors such as smoking or sedentary lifestyle. Cross-sectional studies are also useful for exploring associations between risk factors and health outcomes. However, they cannot establish causality. They only provide preliminary evidence of relationships. For example, if you want to examine whether low physical activity is related to hypertension but have limited resources, a cross-sectional study is a good starting point. There are two main types of cross-sectional studies. The first type examines associations between risk factors and disease, helping us explore potential relationships. The second type focuses on estimating the prevalence of risk factors or behaviors within a specific population. Let's look at an example of the first type of study. This study examined the relationship between employment status and physical activity levels. The purpose of this study is to examine how employment status, such as full-time, part-time, or not employed, and job type, whether active or sedentary, are associated with daily physical activity levels in U.S. adults. From the methods section, we can identify this as a cross-sectional study. It uses data from one cycle of the National Health and Nutrition Examination Survey. One key difference from earlier examples is the measurement method. This study uses accelerometers to collect objective physical activity data, whereas many other studies rely on self-reported measures. The study included 1,826 adults aged 20 to 60 years from National Health and Nutrition Examination Survey 2003-2004 accelerometer data. This is a one-time data collection of both physical activity and employment information. Participants were categorized by employment status: full-time, part-time, not employed but healthy, and not employed and unhealthy. Physical activity was classified into sedentary, light activity, lifestyle activity, and moderate to vigorous physical activity. Looking at the table for men, the first column shows wear time. We can see that wear time decreases from about 395 minutes per day in full-time employees to 285 minutes in the not employed, unhealthy group. Why does wear time matter? Because longer wear time can lead to higher observed activity. To address this, the authors used percentages of time spent in each activity category rather than absolute minutes. Looking at the results, full-time employees had a higher percentage of MVPA and lifestyle physical activity compared to part-time employees, and higher than both not employed groups. The data also included findings for women. You will interpret this information in this week's online quiz. As the data collected using accelerometer, this enables them to analyze time series data. This figure shows hourly physical activity patterns for employed and unemployed healthy men and women. For men, employed individuals are more active during typical work hours, especially from 8 a.m. to noon, and again from 4 to 6 p.m. However, the pattern is different for women. The differences between employed and unemployed women are smaller, and activity may be more evenly distributed throughout the day rather than concentrated during work hours. This suggests that daily activity patterns may vary by gender and role, not just employment status. Now let's look at another type of cross-sectional study, those focused on prevalence. This study examines the trends and prevalence of meeting the 2008 Physical Activity Guidelines for Americans. Focusing on the methods, the authors used 10 years of data from the National Health Interview Survey. You might wonder why this is still considered a cross-sectional study. The key point is that each survey cycle includes a different sample of participants. Even though the data span multiple years, the same individuals are not followed over time. Only studies that track the same participants longitudinally are considered cohort or longitudinal studies. So repeated cross-sectional surveys like NHIS allow us to examine trends over time at the population level, but not individual level changes. The National Health Interview Survey assessed aerobic activity using self-reported leisure time physical activity. Adults who achieved at least 150 minutes per week of moderate intensity activity were classified as sufficiently active, while those exceeding 300 minutes per week were classified as highly active. Both groups meet the aerobic physical activity guidelines. When combined, about 43% of the population met the guideline. Now, comparing across gender and age groups, what do we observe? Typically, men have a higher percentage of meeting the guidelines than women. Also, younger adults are more likely to meet the guidelines compared to older adults, with participation decreasing as age increases. This slide shows the prevalence of meeting muscle strengthening guidelines. Only about 22% of the total population met the muscle strengthening guideline. We can also see that this percentage decreases with age. Why might that be? Possible reasons include physical limitations, increased risk of injury, lower motivation, or less access to facilities as people get older. When we look at meeting both aerobic and muscle strengthening guidelines, the overall percentage drops to about 18%, with 22% for men and 15% for women. Again, this percentage declines with age, showing a consistent pattern across different types of physical activity. Now let's shift to another type of observational study called an ecological study. The key difference between cross-sectional and ecological studies is the level of analysis. Cross-sectional studies examine associations at the individual level, while ecological studies examine associations at the population or group level. This means ecological studies use aggregated data, for example, comparing average physical activity levels and disease rates across different countries or regions. If this concept feels a bit confusing, let's take a look at an example. This study examines the association between occupational energy expenditure and body mass index over a 5-year period. It looks at how changes in work-related physical activity at the population level are related to changes in BMI over time. Let's look at the methods to understand why this is an ecological study. The exposure, occupational energy expenditure, was not measured at the individual level. Instead, it was estimated using data from the U.S. Bureau of Labor Statistics based on job categories and the proportion of people in each occupation. So, the study used average energy expenditure for groups, not individual level data. For the outcome, body weight was originally collected at the individual level, but the analysis used the mean body weight across the population. Because both exposure and outcome are analyzed at the group level, not linked for each individual. This makes it an ecological study. This figure shows changes in occupation-related energy expenditure over time by gender. We can see a noticeable decline, about 140 calories per day for men and 124 calories per day for women. You might wonder whether this is a longitudinal study. The answer is no. Similar to the prevalence studies we discussed earlier, this analysis uses different samples at different time points, rather than following the same individuals over time. Therefore, it is not a longitudinal study, but rather a repeated, population-level analysis. Now let's look at the weight data. The white bars represent actual body weight from National Health and Nutrition Examination Survey. For U.S. men, average weight increased from about 76.9 kilograms to 91.8 kilograms over 50 years. The black bars show predicted weight based on changes in occupational energy expenditure. We can see that the predicted values closely match the actual observed weight. Similar patterns were found in women. These results suggest that the long-term decline in occupational energy expenditure may help explain the increase in body weight at the population level over the past several decades. Now we transition to the second main type of observational study, the prospective cohort study. The key difference between cohort and cross-sectional studies is time. A cohort study is longitudinal. It follows the same group of people over time to see whether an exposure leads to the development of disease. At the start, participants are grouped based on their exposure status. Then, over time, researchers track who develops the disease and who does not. At the end, the results can be summarized in a 2x2 table, comparing disease occurrence in exposed versus unexposed groups. Both relative risk and odds ratio can be calculated, but relative risk is preferred in cohort studies because it directly compares incidence between groups. Odds ratios can sometimes overestimate the association, especially when the outcome is common. Compared to cross-sectional studies, cohort studies provide stronger evidence for causal relationships because they establish temporal order. Exposure comes before disease. However, they still cannot confirm causality as strongly as randomized controlled trials. One advantage is that cohort studies can examine multiple disease outcomes from a single exposure, unlike randomized controlled trial, which usually focus on one primary outcome. On the downside, cohort studies are time-consuming and expensive because they follow participants over long periods. They are also less efficient for studying rare diseases, since few cases may occur during the study period. Finally, confounding is a concern. Many other factors may influence disease development, and even with adjustments, it can be difficult to fully control for all covariates in a longitudinal observational design. We will use two classic cohort studies in physical activity epidemiology to illustrate how this design works. The first is the Harvard Alumni Health Study. This study was led by Ralph S. Paffenbarger Jr. at Harvard. The participants were male alumni who attended Harvard University between 1916 and 1950 and were still alive in 1966. Data on lifestyle and health were collected at multiple time points: 1962, 1966, 1977, 1988, and 1993. This study followed the same group over time and did not enroll new participants. The main exposure of interest was physical activity, measured through self-report. The primary outcomes were chronic diseases, especially coronary heart disease, assessed using baseline and follow-up surveys. This is a sample of the physical activity questionnaire used in the Harvard Alumni Health Study. It includes questions on daily activities such as stair climbing and walking, as well as structured exercise. Participants also reported the type, frequency, and duration of physical activities over both the past week and the past year. These responses were then used to estimate overall energy expenditure and physical activity levels. Why did researchers choose Harvard alumni? One key reason is high compliance. This group was more likely to respond to follow-up surveys, which helps reduce loss to follow-up, a major source of bias in cohort studies. Think about who is more likely to drop out: individuals who are less healthy, less active, or from lower socioeconomic backgrounds. Losing these participants can bias the results. Harvard alumni were generally well-educated, which made them more likely to monitor their health and accurately report medical history and lifestyle behaviors. In addition, researchers had access to historical data from their college years, providing valuable baseline information. This cohort has generated multiple publications, which is common for large, long-term cohort studies. One finding examined the relationship between college sports participation and coronary heart disease mortality. In this study, individuals who participated in varsity athletics had a lower risk, about 0.6 times the risk, compared to those who did not participate. What might explain this? Former athletes may have developed lifelong habits related to physical activity. They may also have higher fitness levels due to years of training. In addition, they may have greater knowledge and interest in health behaviors, including both aerobic and resistance exercise, which could contribute to long-term health benefits. This is another paper from the Harvard Alumni Health Study, published about 20 years after the study began. It examines the relationship between physical activity and longevity. On this graph, the y-axis represents death rate, and the x-axis represents physical activity level. Results are shown across different age groups. The group with less than 500 kilocalories per week of physical activity is used as the reference. What do we see? Higher physical activity levels are associated with lower mortality risk, and there is a clear linear trend across all age groups. Also, younger groups have lower mortality risk overall, which is expected. The authors also estimated how physical activity relates to years of life gained. On average, being physically active was associated with about 2.2 additional years of life. The timing matters. The earlier you become active, the greater the benefit. For example, becoming active at ages 35 to 39 is associated with about 2.5 years of life gained, whereas starting later, at ages 75 to 79, is associated with about 0.4 years. This highlights the importance of adopting an active lifestyle earlier in life for greater long-term benefits. The next classic cohort study that I want to introduce is the Aerobic Center Longitudinal Study. The project began in 1970 and continued through 2006, enrolling over 80,000 participants. Data were collected through Cooper Clinic examinations, including clinical tests, body composition, and cardiorespiratory fitness. Participants were followed for mortality outcomes until 2003, resulting in about 4,000 deaths. In addition, 6 periodic surveys collected information on lifestyle behaviors such as diet, smoking, and substance use. What is the key difference compared to the Harvard alumni study? A major advancement is the direct measurement of cardiorespiratory fitness for each participant, rather than relying only on self-reported physical activity. This reflects a growing recognition of the importance of fitness as a health indicator. Why are the 4,000 deaths important? They provide enough outcome events to assess mortality risk and calculate associations, such as relative risk, using approaches like the 2x2 table. Cardiorespiratory fitness in the aerobic center longitudinal study was measured using a treadmill test with the modified bulky protocol. This method is more practical than a full maximal test with direct oxygen uptake measurement, but still shows a very high correlation with VO2 max. Cardiorespiratory fitness was then categorized into 5 groups based on relative fitness levels within the sample. The lowest group, quintile 1, represents the bottom 20%, while the high fitness group includes the upper 40%. This raises an important point about feasibility versus accuracy. Direct fitness testing is more objective and accurate than self-reported physical activity, but it is also more resource-intensive. Again, the aerobic center longitudinal study has produced many publications. This paper examined the relationship between cardiorespiratory fitness and breast cancer mortality. It included 14,551 women aged 20 to 83, with 68 breast cancer deaths over an average of 16 years of follow-up. Because cardiorespiratory fitness was categorized into 3 levels, low, moderate, and high, the analysis can be thought of as a 2x3 table, rather than a simple 2x2 table. What do we find? Compared to the low CRF group, the moderate CRF group had about a 30% lower risk of breast cancer mortality. The high CRF group had about a 55% lower risk compared to the reference group. This shows a dose-response relationship, where higher fitness levels are associated with lower mortality risk. Another influential finding looked at how physical activity impacts stroke risk. It showed a significant inverse relationship between physical activity and the risk of stroke in women. The last study was looking at the hazard ratio of type 2 diabetes by fitness group. Q1 is still the lowest fitness group. What did you find here? The perfect dose response. Interesting how linear this relationship is. Lastly, let's briefly introduce another observational design, the case control study. This section is optional, but the key idea is to understand how it differs from a cohort study. Let's revisit the same framework used in cohort study. In this design, we start with individuals who already have the disease and those who do not, and then look backward to determine their exposure history. Compared to cohort studies, case control studies are more cost-effective and efficient, especially for rare diseases, because they often use existing data rather than requiring long-term follow-up. However, when estimating the association, we typically use the odds ratio. This is because we do not know the total number of exposed and unexposed individuals in the original population, so we cannot directly calculate incidence or relative risk. Let's look at an example of a case control study. This study investigates the relationship between physical activity and breast cancer risk. Researchers first identified women with breast cancer from hospital or registry records. These are the cases. Then, a comparison group without breast cancer was selected as controls. Participants were asked to recall their past physical activity during adolescence and young adulthood. This fits the case control design because it starts with disease status and looks backward to assess exposure. Because of this design, the association is measured using odds ratios rather than relative risk.